Use this YouTube stuff. Okay. All right. Standard transaction code set. So I'm going to kind of, for the sake of time, skip some things here. But I am going to ask for some ICD-10, ICD CPT books. Let's go to page 130, where it talks about official guidelines for ICD-10. Okay, I'm going to pull me up a little chair here. Man, I've been wanting me some fajita tacos last night. Give me some today. Shh, my doctor didn't hear me say that. Okay. Oops. Okay. All right. So official guidelines for coding and reporting is a set of rules developed to accompany and complement the official conventions and instructions provided by the ICD-10 coding manual. The guidelines including definitions, standards, rules, general coding guidelines, and 21 specific chapter coding guidelines. Adhering to guidelines when assigning an ICD-10 diagnosis code is required by HIPAA. Remember, there's different titles of HIPAA. HIPAA is not about privacy and security. There's different titles of HIPAA. It is important that the healthcare provider and the coder work together to achieve complete, accurate documentation, code assignment, and reporting of diagnosis codes. Diagnostic code book conventions. To become a proficient coder, it's important to develop an understanding of the conventions and terminologies of the ICD-10 coding system. Conventions are rules, principles for determining diagnostic code when using diagnostic code books such as space, typefaces, indentions, punctuations, symbols, instructional notes, abbreviations, cross-reference notes, and specific usage of words such as and, with, or due to. We just got through talking about due to. These rules assist in the selection of correct codes for the diagnosis encountered. Some of the conventions for ICD-10 are listed on the next page. However, the insurance billing specialist, you beautiful ladies, should read all the information included in the introduction section of the coding manual, which will provide a complete outline of all conventions used in the manual. So now we have abbreviations, punctuations, and symbols. Okay. So now looking at this on page 131, here's a tabular list of all the chapters of, and I think I mentioned that up there, didn't I? Oh, I must have erased it. Okay. All the chapters of diseases. So you have neoplasm has its own chapter. Those are the cancers. Infectious diseases and parasitic diseases. That's chapter 1. That's like your AIDS, your HIV, different things like that. Chapter 2 is neoplasms. Chapter 3, blood and blood-forming organs. Certain disorders involving the immune system. You have chapter 4, endocrine, chapter 5, mental behavior, and so on and so forth. Now, look at the codes to the right of the page. It begins with an alphabet and 2 numbers, okay? So let me write a little small difference here. Okay, so in ICD-9, and sometimes you have some doctors, they still get used to ICD-9-CM. And then you have ICD-10-CM, okay? Now, used to be 3 numbers, okay? 4th, 5th, and sometimes 6, okay? So this would be a number, this would be a number, this would be a number, okay? This is known as your 3 digits. What is the first 3 digits of the diagnosis code? And this would be it. First 3 digits of the Diagnosis code. Okay. Now, this right here, when you add a fourth number or a fifth number or even a sixth number, this would be your fourth digit, your fifth digit, your sixth digit, if necessary, NEC, if necessary. Okay? How you would know if it would be necessary? Glad you asked that question. It's because that diagnosis code, when you go in volume 1, it's going to have a red dot in front of those first 3 digits. Okay? That red dot is going to let you know that if it just has first 3 digits, that red dot lets you know it needs a 4th digit. If it has the first 3 digits and a 4th digit, that red dot is going to let you know it needs a 5th digit. It's going to have a separate area underneath those other specified areas to say it's either this code with the 5th digit, 2 more numbers added behind it, or 1 more number added behind it. It's either this code or that code. So we're going to get into it, but I'm just going in short. So anytime when you go in volume 1 in the tabular list to find and verify your code, you always verify where? In volume what? 1.
Oh, yeah, 1.
You always verify volume 1. You find your code in volume what? 2. You verify in volume what? You find your code in volume what? 2. You verify in volume what?
1.
Very good. So when you see this red dot in front of a 3-digit number, or if it has 4 digits, or even if it has 5 digits, in the ICD-9, that means that you're going to code to the best specificity. They say high specificity, but I like to say to the best, because high is kind of like, I don't know, kind of confuses me. Now, here we go. With ICD-CM, since this was founded, I want to say 2014 or 2015, I can't quite remember. It has 3 digits as well. It has its 4th and 5th digits, and sometimes an anchor digit. And we're going to see what that is in a minute. This is going to have right here, a letter. Okay. A letter. Okay. And each letter represents a chapter of that disease. Okay, like we just saw on that page 131. Okay, so it's going to start off with an alphabet. Let's put on here alphabet letter, an alpha letter. Okay, it could be E, K, A, B, C, D, E, F, G, all the way down to Z if it wants to. Okay, now this will have a number. This will have a number. Okay, this may require a 4th digit. This may require a 5th digit. This may require a 6th digit. And sometimes this is going to require an X. This goes up here, so I'm just trying to say X. And whatever that X anchor is. Okay, so we're going to call this an appointed anchor. Okay? All right. So now, why did Matarpa write like this? And it's going to be the same way here. It's going to have a red dot in volume 1. Okay? The first 3 digits are going to be boxed off. Okay? Now, not boxed off, but the first 3 digits are going to represent the category of that disease or that illness. Is everybody getting this? Okay. So if you go and verify what volume? 1. Very good. Then if you see the 3-digit diagnosis with a letter and 2 numbers, is that red dot is telling you that it requires a 4th digit. If you see a 3-digit and a 4th digit and it has a red dot by the main heading, then it tells you it requires a what? 5th digit, 6th digit, and sometimes an anchor. Okay, we're going to learn what those X anchors are. I call them an X anchor, but it's something else right now. Okay, but are y'all getting this? So the reason why you cross-reference it, whatever a well woman exam is in ICD-9, you're going to, if that doctor's still stubborn on using ICD-9, then you need to find out, okay, well woman diagnosis code is this. Well, what is well woman diagnosis code in ICD-10? They're saying the same thing, except one is ICD-9 and one is ICD-10. If you're going to work in the insurance industry, sometimes you're going to find a few slip-ups where some folks are still billing with ICD-9 and maybe half with ICD-10 because they can't find whatever they need in ICD-10, but it's easy for them to find it in ICD-9. That's fine. Just as long as you send an edit message saying you must use ICD-10 or whatever that edit message is for that insurance company. Are y'all getting that? Okay. Now, the reason why I wrote it like this is because I want y'all to become familiar and comfortable with the fact that whatever is interpreted in ICD-9 is the same similar thing in ICD-10. The only difference is that they're using an alphabet and two numbers. That is it. Plain and simple. Okay? Nothing to be afraid of. Okay? All right. Fantastic. All right. Now, if you're working in a doctor's office and they still using ICD-9 and you're doing billing, let the doctor know, sir or ma'am, that office, we need to be up to date. This is 2018. It's about to be, we enter in the second half of the year. So we need to get a 2019 book or have one on pre-order. But right now we need a 2018 because this is going to slow down you getting your money and you wondering why you having them boo-boo looks because you're not making XYZ dollars a month. I'm telling you why you got them boo-boo looks on your face, okay? Because you're not using the correct book. And this is why this is happening, and it's holding up my progress of the money. And I want to make sure you get all the money that you need in order for your tax lady to do what she needs to do so we can get us our Christmas bonus checks, okay? Because everybody like they what? Bonus checks. Lord knows I do. Okay. All right. Does everybody get that? Okay, fantastic. Okay, so diagnosis code book, blah, blah, blah. Abbreviation, punctuations, and symbols, blah, blah, blah. Okay, include notes, exclusion notes. So excludes, includes. Let's get an understanding on that. Includes is a note appears immediately under the 3-character code title of the tabular list, like I just got through saying, and provides further definition and examples of additional content to the category. Excludes, there are 2 types of excludes used in the tabular list. Excludes one note indicates certain codes that should never be used at the same time as the code selected, highlight that, and is used when 2 conditions could not possibly occur at the same time. Is everybody getting this? Okay, so you can't have one code and this code, it's kind of hard to explain. Okay, exclusion 2. Notes indicate that condition selected is not part of the excluded condition. However, it is possible for the patient to have both conditions at the same time. It is acceptable to report both the code and the excluded code together when applicable, okay? So now it's giving you examples of that in 5-11. So it says pain in throat and chest. Okay, so excludes epidemic malagia. So we know algia is what? Pain. My is what? Muscle, okay? And then it says exclusion 2, jaw pain, pain in breast. Now, if I'm having pain in throat and chest, well, yeah, like right now, I have pain in my jaw, okay? But there's a sheath of muscle from my jaw right here all the way down that goes to breast. There's sometimes infection, especially I had my tooth pulled, so sometimes infection can affect all of this right here, and it comes down to right here, Okay, so therefore, I may be having some pain in my breast, not so much in my breast tissues itself, but the pectoral muscles of my chest where my breast is. So y'all getting this? I'm talking muscles, not fatty tissue. Okay, breast is fatty tissue with glands and all that beautiful stuff. Okay, all right. Now, that's an exclusion. It exclusion is you can have this. Exclusion 2. Exclusion 1 is you that's not possible to have that and that. No. Okay. All right. You can have muscle pain, but it's going to affect what? The jaw area or the what? Breast area. Okay. I want y'all to be sure to get a real good understanding of that. Not at all related to that. Yes, pretty much. Second one is I'm not related to it. Yes, but more specific. But more specific. Exactly. You got it. All right, so let's look at default codes. Default codes code is shown next to a main term in the alphabetic index and represents the condition of that is commonly associated with the main term, or it is the unspecified code for the condition. So, for example, if the electronic health record documents appendicitis, but does not list acute or chronic, then the default code should be assigned. Okay, so if the doctor says in assessment, remember we have subjective, objective, assessment, and plan. Okay, so under assessment, if the doctor says appendicitis, then appendicitis is appendicitis. It's just all there is to it. If he didn't say acute or chronic, then it's just plain old what? Appendicitis. Now, if it's acute, then that means he has a pain, but it's subsiding or it's passing through. It hasn't burst. It's just pain right there, but they've done some sort of ultrasound or some sort of X-ray to see that it's not so bad to where it's going to be septic to that person's life. Okay, then it's acute. But if it's something that's happening all the time and it's on the verge of bursting and being septic to that person's life, then that's what? A H&P that's deemed for what? Admission to the what? Hospital to have an immediate what? Surgery. Okay, chronic is long term, acute is short. Okay, everybody got that? Okay, fantastic. All right, and make sure too, ladies, when y'all see a billing process and that doctor is doing such things like this, appendicitis, make sure, that's why I said you have to study the functionality of that body. You want to, and when you look at those codes, you can always ask the physician. Now, it depends on the attitude of the physician, because not every physician, I'm going to tell you the truth, is approachable. Now, all of them are nice to have a nice little conversation with you, because some of them get that complex, that God complex. Okay, so you do better talking to a nurse, okay, and asking them, and the nurse knows how to work with them. They know how to, or know how they mind tick, and they can tell you if it's going to be acute or chronic. If they don't know, then it's just plain old what it is, and that's it. And it still more than likely will get paid or appended. If it's get denied, it's going to tell you why. Either way. Okay. What are the 3 outcomes of claims processing from a insurance company on an EOB? The claim is going to get what? Or denied. Very good, ladies. Y'all got this. Okay. Gender and age codes. Okay, so diagnosis codes must match the age and gender of the patient. If an adult female patient with breast cancer is seen, excluding carcinoma in situ, we're going to talk about that later, and skin cancer of the breast, a code from the ICD-10-CM neoplasm table must be used. Now, we're living in an age, and have to have this conversation where sex change is happening. Okay, it's becoming what? Common. Okay, let me say this to my I'm just gonna say, let me say this to my Jesus folks. Okay, because I'm a Jesus folk. Okay. You cannot express your political or your religious views per se in the work. You have your beliefs. That is your beliefs. But then there's your job. Okay? Trust me, I am a licensed minister. I know what I'm talking about. I prayed, I saw God on it. God gave me some wisdom keys how to handle this, and I'm hoping to help you too. Okay. If that person put on there that they are male, but they were born what? Female. Okay. They have to complete the form according to their government birth certificate. Okay. Why? Because your government birth certificate links to your government social security card and your government Texas driver's license. Now, but am I right? I got that. And guess what? I respect that. Yes, I do. But when it comes to claims processing and billing to keep you from getting a bill from us, we have to comply with CMS and its coding guidelines, rules, and laws. I'm not trying to make it hard for you. The government not trying to make it. It's all a part of the paper trail and how we process things. That's just how it is, sweetie. Now, I can call you Mr. all day long. That's fine. But when it comes to paying those claims, I have to process according to what your government name, information, your sex, and all that says since the day you were born and came here. I have to do what the government says. Now, if you went through some special provisions, and I'm sure it's out there, and you got your social security number changed, you got your birth certificate changed, they have destroyed the original document, which I highly doubt they'll do that. Okay. Then perhaps we can go along with that guideline, but you're going to have to kind of go with, you're going to have to answer to HR of your company where you work, where you pay those premiums through your paycheck, and then you got to submit that to the insurance company. So see all the work you have to do. I'm not trying to delay nothing of your personal life, of how you want to handle your personal life and how you want to live your life. That's not me. I'm trying to make it plain and simple for you so you don't come get upset and judge us, because we ain't judging you. We doing our job. We just have to do it like this. That's how it works. Okay? Now, same thing works for a man. He can have the surgery and be ma'am, lady, Mrs., Miss, all day long. But if your government birth certificate says the sex and who you are and all that stuff, then I have to go according to how to file you on the insurance. If not, it's going to kick us back and we're going to have to bill you for all that you owe. Okay? That's just paperwork and how it works. Am I helping you out today? Okay. So in other words, what is Miss Harper saying? Miss Harper say, just keep it separate, but do your job. Let God be true. And I'm still going to love you. Don't make me no never mind. I'm still going to love you. Okay? All right. Now, you're going to have some folks that going to argue why you need my social security number. Because the insurance company has it from the HR where you work at, and I need that to verify this. So in case you don't pay the bill and we have to do an agent report, then I need to send you a bill. And if you don't send that bill, then I need to put a ding on your credit report. Okay, moving right along. Selection of a coding manual. General coding guidelines. Here we go. Locating a code in the ICD-10. Level of detail coding. Okay, so locating a code in ICD-10. I think I already told y'all that. Blah, blah, blah. Level of detail in coding. LCD-10 CM codes are composed of 3, 4, 5, 6, or 7 characters. Digits, characters, same thing. Y'all see that? Okay. Some conditions may be reported with a 3-character code. However, if the code is further subdivided, it should be reported at the highest number of characters assigned. This is commonly referred to as coding to the highest level of specificity, okay, or to the best level of coding. A code is invalid if it has not been coded to the full number of characters required for that condition. Okay, so it's not saying that you're wrong if you're missing some characters. It's just saying you off by 1 or 2 characters. You need to correct that, resubmit the bill, and then we'll possibly pay you or deny you. We can't guarantee payment, but we'll pay you or deny you. Okay, signs and symptoms. Codes that describe signs and symptoms are acceptable for reporting purposes when a related definitive diagnosis has not been established. This is reported using codes from Chapter 18 of the ICD-10 CM Coding Manual. Okay, blah, 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 blah. When coding for office or outpatient services, if the final diagnosis at the end of the encounter is qualified by another following terms: apparent, likely, might, possible, probably, questionable, rule out, suspected, or suspicion of, do not code these conditions as if they existed or were established. You may want to highlight that, circle that, box that, however you want to do that. Instead, document the condition to the highest degree of certainty for each encounter or visit. So, for example, signs, symptoms, abnormal test results, or other reasons for the visit, and code the chief complaint, which is in subjective, sign or symptom. Sign is he looks pale, or she looks bothered. Okay. Symptom is his temperature is 105. I don't know. That's ridiculous. Let me say 101.2, because 105, you just on fire. Your brain is fried. Okay. Symptom is he got bumps all over his face and his cheeks are swollen. He look like he got mumps. You know, he need to eat some sardines. You know, that does cure mumps. I just want to tell you that. I love sardines. I do. Anybody like sardines? Yeah, I do too. Occasionally. Yeah. I like my sardines with mustard. Yeah, I like it in that mustard sauce with them onions and some saltine crackers. Okay. So yeah, signs and symptoms. Okay. To this contrary to coding practices used by hospital health information management departments for coding, the diagnosis code of hospital inpatients. If you were to follow guidelines used for hospital coding and the patient was suspected of having a heart attack, this would be coded as a confirmed case of what? Myocardial infarction. What did I say another term was myocardial infarction? What is another term for that? Huh? Heart is about the heart, but it's another term for saying heart attack. No, not a stroke. That's ischemic transient attack. That's another term for that. But myocardial infarction, I'm having a myocardial infarction. That's a heart attack. Myo means what? Muscle. Okay. Cardio means what? Heart. Infarction means what? Attack or compression or decompression. Okay. So if a person says, I'm having a myocardial infarction, you mean a heart attack? Yeah, I'm having a heart attack. Okay. All right. The same holds for possible epilepsy. If the patient had a convulsion and probable cause, but had not been proved, you could code the convulsion. What we know, that popular word is called syncope. Syncopy. Syncope. Syncope is like dizziness, unbalance, that kind of thing, kind of convulsion, looking, acting, whatever. It's a broad code. Okay, so the following instances in which signs and symptom codes can be used. No precise diagnosis can be made. You can use code for signs and symptoms. Signs and symptoms are transient and a specific diagnosis was not made. Okay. Provisional diagnosis is made for a patient who does not return for further care. Okay. So if you have some patients, they'll get mad if the doctor takes too long in the room. They sit in the room. I've been sitting here for 30 minutes. And sometimes you can go and that doctor walk in. Where's the patient? Where's the patient? Well, let's see. Did he go to the restroom? Did y'all see the patient? Did the patient walk? Well, we saw him walk out. Well, when y'all saw him walk out? Oh, he walked out about 15 minutes ago. He went home. Okay. But now the nurse that may have done what? Their subjective conversation, took the vital signs and all that stuff, and may have done their CC. CC means what? Chief complaint. And the chief complaint was, I have headaches, my stomach hurt, and I feel like I want to just throw up. Okay. So that means at that point you can code, and there is a code. Patient was not seen. The encounter of the patient was present, however, was not further seen. There is a code for that. Patient had fever, lethargy, and the patient was sweaty. Okay, you can code those things, okay, in there. Now, whether you can bill it, no, but you can code it for documentation. So in case something happens to the patient on his way home, and they may find that he, on his phone, everything is so technological these days. They can track pings on your phone where you've been. Well, he came to the doctor's office. La 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 la. Well, yeah, we have it. He was here for this subjectively. We looked for him. We wrote in the assessment that the patient was no longer seen because he left. And he left, and CC's diagnosis was, the signs and symptoms was fever, lethargic, and sweaty. And he left, he never came back. You can document that. Please document that, because anything happens to that patient at home or on their way home, and they tracking pings on that patient's phone, see where they last went, you got coverage on your end of what happened.
What about if they tell you the doctor was taking long and they had to go to emergency?
Right. So if the doctor was taking too long and they went to the emergency room, that's perfectly fine. As long as you have tangible evidence that he was in that office. He was not necessarily seen by the physician or the nurse practitioner or the PA, but you have tangible evidence that he was there. Now, if he says, I'm going to the emergency room so I could be seen pronto, okay, that's fine. But you just can't bill it. You can only document it, but you can't bill it. Does that make sense? But now when he gets to the ER room and they see him pronto savvy, then yeah, then they got every right to bill, because now he's being seen by nurses, nurse practitioner more than likely, or physician assistant, or a doctor, someone of licensure, providership to take care of him. Yeah. So that's not a problem. That won't be a problem. Yeah. But documentation, ladies, is what? Everything. Y'all gonna learn that in the EMR class. Documentation is everything. Cover your tracks, paper trail. Paper trail will be your friend. Okay. Now let's move on. And it gives some examples of provisional diagnosis, transient sign, all that wonderful, beautiful stuff. Okay, move around along. Conditions that are integral part of a disease process. These are signs and symptoms that are typically associated with a disease process that should not be assigned as additional codes. Okay. So again, I gave that lovely illustration about diabetes mellitus. Patient had pancreatic pain. Patient had stones in their pancreas. Okay. Now it's obvious the patient is on what? High blood pressure medicine. He battles with high blood pressure. The patient is swells up at times, so he takes diuretics to remove some of the swelling, furosemide to remove some of the swelling out of his body. You cannot code for hypertension and lymphedema because you see that prescription on his list. No, you only code for what he's there for and what he commonly comes in for, okay, at that time. All right, conditions that are not integral part of a disease, okay? And I just spoke that in a minute. Hold on. Okay. Signs or symptoms that are not typically associated with the disease process should be reported when documented. Okay, so we'll talk a little bit more specific on that later. Multiple codes for single condition. Okay. In some cases, 2 codes will be required to describe a single condition. Use additional codes from the tablet list will guide the coder as to when it is appropriate to report a secondary code. When determining which code to sequence first, the additional code will be reported as a secondary code. Do y'all get this? Code first notes that are indicated in the tablet list and typically used for identifying an underlying condition. The underlying condition is always reported as the primary code. Okay. Now, diabetes, for example, again, let's just use hypertension. If a person battles with hypertension, okay, sometimes it may manifest, this is underlining. So this is your root word, okay, your root word. Your root word may branch out other trees of disease, okay? It may branch out other stuff, okay? So hypertension may branch off diabetes. Diabetes may branch off glaucoma. Diabetes may branch off kidney failure. Diabetes may also branch off heart. Okay, so diabetes is one big old tree with many branches. Oh, y'all seen that? Just like that. That's what it means. So this is underlying with other branches of diseases that could possibly, not always, but possibly branch up. Okay, acute, subacute, chronic conditions. When the documentation mentions that a condition is both acute, subacute, or chronic, or separate codes exist in the alphabetic index, both are coded with the acute, subacute sequence first, followed by the code for a chronic condition last, okay, or second. And we'll look at that. We'll do some coding exercises so y'all can understand that. I love Faye Brown. If I can find my Faye Brown book, Faye Brown makes it so simple. I love Faye Brown's teaching, her books. Okay, combination code. A situation in which a single code is used to classify 2 diagnoses or diagnosis with an associated secondary process or diagnosis with an associated complication. Identify a combination code by referring to the subterm entries in the alphabetic index and by reading the inclusion or exclusion notes of the tablet list. If the combination code does not specifically describe the manifestation or complication, use a secondary code, okay? Moving on to sequela. A sequela is a late effect or a condition produced after the acute phase of an illness. There is no time limit on when a late effect can be used. Coding of a sequela generally requires 2 codes. The nature of the sequela is sequenced first, and the sequela code is sequenced second. Okay, so let me give you an example. Okay. Johnny fell off a tree last summer, okay, and fractured his leg, okay. It is now wintertime, about a year and a half later. Johnny feels muscle tension in his right tibula and fibula of his leg, okay? And he feels pain, okay? And he's seeing his pediatrician. His pediatrician is going to give him a prescription for ibuprofen. The pediatrician already knows the history of his fall last summer, and he's just feeling a shift in the seasons, and he feels that his bones are aching. So he's just having aching of the bones, and the fracture is still yet healing, but is getting used to the seasons. So he's going to forever feel that. Okay. What needs to be coded first is aching of his right leg or aching of his right tibula or fibula. Does everybody get that? And then second would be what? The fractured leg. There you go. You got it. You got it. You got it. Are y'all getting that? Because he came in for pain in his leg. It is aching and it's cold outside. And oh my God, it's the gravity of the air is just killing me. And so the doctor's gonna be like, dude, just because you broke your leg last summer, just take some ibuprofen. You'll be all right. Come back to see me next week. Tell me how you work. Oh yeah, I'm not being casual like that, but I'm just saying, some doctors get along with their patients like that, and that's it. Pay me $150. See you next week. Bye. Okay. So that's how it works. But you got it. Are y'all getting this? Good. Good. I'm glad we're going through all this. Impending or threatened condition. Codes that are described as impending or threatened should be referenced as such the alphabetic index and reported accordingly. If there are no subterms under impending or threatened for the condition described, report the existing underlying conditions. Does everybody understand that? Reporting the same diagnosis more than once. Oh, my battery is running low. Okay. I may have to move my computer down a bit. Oh, okay. Yeah, just a bit. Just a bit. Just a bit. Okay. Fantastic. Okay. Okay, reporting the same diagnosis more than once. Let's look at that. Each unique ICD-10-CM diagnosis code may be reported only for once an encounter. This applies to bilateral conditions where there are no distinct codes to identify laterally or two different conditions are classified to the same diagnosis code. Laterality, okay? When reporting bilateral sites, the final chapter of the code, ICD-10, should be selected to indicate laterality. I can't even say the word right. The right side is always character 1, and the left side is always character 2. In those situations, when a bilateral code is given, the bilateral character is always 3. If the side is not identified, an unspecified code is reported, which is either 0 or 9, depending on whether it is a 5th or 6th character, such as example 5-28. Okay, so we have crushing injury of thumb, okay? And so we have a crushing injury of thumb unspecified, crushing injury of right thumb, crushing injury of left thumb. Do you see how that 1 and that 2 at the end makes a difference? Okay. If it just says unspecified site, then you use 00. Do y'all see that? Okay. All right, fantastic. Documentation for BMI, which is basmati, okay, body mass index, okay, and pressure ulcer stages, okay, it has its own thing. Kind of skipping around here for the sake of time. Syndromes, okay, so I'm just going to skip that. Deficiencies, neoplasms, benign tumors, we talked about a lot. Coding of diabetes mellitus on page 139. Page 140, hypertension, pregnancy, delivery, all those wonderful coding rules for that. We're going to skip around. Let's get to talking about burns and corrosions, adverse effects, poisoning, underdosing, and toxic effects. All the rest of those other coding rules, we can get to that later once we start doing some practice coding. Okay, so you have burns and corrosions. Burn codes are used for reporting thermal burns, except burns that come from a heat source such as fire, hot appliance, or those result from electricity or radiation. Corrosions are defined as burns caused by chemicals, okay? Burns are classified by depth, extent, or an agent. When multiple burns are reported, a separate code for each burn is reported. The code reflects the highest degree of burn. So you have first degree, second degree, third degree. Okay, very good. All right. An additional code for category T31 or T32 should be reported to identify the total body surface area, TBSA, total body surface area for all sites. Think of the body as a whole and not the body parts as whole. The adult is divided into 3 regions. You have the head, the arms, each one, the trunk, front and back, and you have the legs, okay, and the peritoneum. Okay, children and infants' bodies have different regional percentages, okay? So everybody has a percentage of weight, but it should all equal up, I think, to like 100% of some fashion, okay? Now, when we get ready to do that, you have in the ICD-10 book, the ICD-9 book, they do have categories if it's third degree, second degree, fourth degree burn. They do have categories for lacerations, you know, if the laceration, but that's in procedure coding, if the laceration was so many centimeters long, okay? You're going to learn all that later. Adverse effects, poisoning, underdosing, toxic. Adverse effects, poisoning, underdosing, and toxic effects are reported using combination codes from the range of T36 to T65. No additional external cause code is required. Okay, the table of drugs and chemicals is found after the alphabetic index, section 2, and contains a classification of drugs and other chemical substances for identifying poisonous states and external causes of adverse effects. An adverse effect is defined as an adverse or pathological reaction to a drug that occurs when appropriate doses are given to humans for prophylaxis, which is for prevention of disease, diagnosis, and therapy. When an adverse effect occurs, for example, drug reaction, hypersensitivity, or drug intolerance, the idiosyncratic reaction, a code is assigned to the diagnosis that classifies a specific reaction or symptom. So, for example, dermatitis, syncope, tachycardia, urticaria. Okay, the specific reaction or symptom from use of the drug is reported as the primary code, followed by a code from the table correct code assigned by the adverse effect of the drug. The code for the drug should have a 5th or a 6th character. Okay, all right, so we just going through all of this. Poisoning, here we go with poisoning on page 144. Poisoning could be taking the wrong medication, receiving the wrong medication, that does happen, taking the wrong dose for the right medication, receiving the wrong dose for the right medication, ingesting a chemical substance not intended for human consumption, overdose of chemical substance, prescription drug taken with alcohol or over the counter, mixing prescription drugs and over the counter medications without a physician's advice or consent, that does happen. Okay, external causes of morbidity or classification of codes where you look for external causes of injury rather than disease. The code description referred to as circumstances that cause injury rather than nature of the injury. The code are also used to code the adverse reactions of medication. So here's some examples there. So we're just going to kind of skip around. Okay, chronic diseases, Handy hints for diagnosis coding. I'm going to let y'all read that. Computer assistant coding. Okay, so let's step a little bit. Page 148. Computer assistant coding is software that automatically generates a set of medical codes for review, validation, and use based on clinical documentation provided by the healthcare practitioners. So sometimes you can program certain diagnosis codes if you know your physician use those codes pretty much all the time. You know, sometimes it'll automatically imprint it, like on a smartphone. If you use certain words all the time, it'll automatically bring it up. All you got to do is just press that word and not have to spell it out. Okay. Many factors have pushed medical practice to accept CAC, computer assisted coding. We're on page 148. Some of these factors are as follows. So shortages of coders throughout the United States, financial need to reduce the cost of filing insurance claims. Okay, so you may want to kind of speed up your billing process. Okay, she laughing at that. Yeah. Increased complexity of coding systems with implementation of ICD-10, adoption of the electronic health record, advancement in natural language processing, frequent changes in code numbers and coding rules and regulations, compliance of liability for increased erroneous claims. Okay, so here are some of the reasons for that. CAC uses technology options such as structured input or natural language processing. In structured input, the physician inputs information on a data entry screen that has point and check fields and pull down menus, structured templates, or macros. The system prompts the physician for detailed information. Words and phrases selected or linked to a diagnostic and procedural codes that are automatically generated when all fields are completed. Input the medical information results in a completed document with the appropriate level of detail. Recommended diagnostic and procedural codes are then checked and edited by the coder. So sometimes you can't always use a code that's always there. You have to make sure the documentation supports that. Remember, when I get ready to teach y'all electronic medical records, you can't always copy and paste diagnosis codes or copy and paste notes. Okay, that does happen. It will happen at times because you're trying to shortcut your time and get your production done. I get that. But make sure it matches everything what's going on with that patient today. And you'll see exactly what I'm talking about when you get ready to look at that. The future of diagnosis coding to improve, I'm on page 148 at the bottom, to improve the ability to function in an electronic environment, to allow for collaborative web-based editing by interested parties while under peer review, to incorporate international multilingual reference standards for scientific comparability. Okay, moving right along, they have procedure. Okay. Okay, and that is it. Now we're getting ready to do procedure coding. Okay, chapter 6. So we'll pick up chapter 6 on Thursday. Yeah, Thursday. We have basically completed chapter 5. It's been very interesting. How do you girls feel about that? You understood it better. Very good. Glad to hear that. Very good. How about you, Amy? You've been quiet all day. Yes?
Yeah.
It's going? Okay. Okay.
I was reading it myself and I was like, yeah, I was only remembering whole words
Mm-hmm.
because supposed to be important. But as you went through it, I was like, oh.
Very good. Very good. And it's all coming together. How you feel, Ebony?
I feel good about it. At first, I'm like, oh, we have to memorize all this. Like you say, once we get the working and actually applying, it'll still all come.
Yeah. Good, good. And it happens when you're new to the field. It happens.
I don't mind asking questions.
Yeah. It's better that y'all ask questions. Even while y'all working on the job, Amy, ask questions. Ask. It's better to ask than to assume and make a mistake. Ask. And keep y'all little tablet with you.
That's why I'm gonna end up like you got a lot of papers out there towards the end. I'm gonna get one tablet and kind of put all what's important that we talked about to where I won't be and have it all together.
Amen. Amen. Well, I enjoy you ladies. Thank y'all so much. And I will see y'all on tomorrow. And so we'll do chapter 6 on tomorrow. And